Okay, why don't we get started? On behalf of the organizing committee, welcome to the opening plenary of the 4th Symposium on Global Health Policy Research, which is organized by the Global Health Policy Research Forum. My name is Jeremy Shiffman from Johns Hopkins University. We've invited 6 of the world's leading scholars working on global health policy to offer their thoughts on how COVID-19 is and will be shaping the future of global health policy research. We're expecting to hear some very thought-provoking ideas. Each of them is going to be offering 5 minutes of comments, and then we'll open up for a discussion moderated by myself and Grépin of the University of Hong Kong. And that will include time for panelists to respond to questions from those listening in today. So please share your questions as the panelists speak using the Q&A function. I'll make a few brief introductory remarks about the symposium and about a new organization we're launching on global health policy research before introducing the panelists. Next slide, please. So this is the 4th in a series of symposia on global health policy research, the first and second of which were held at American University in Washington, D.C. in 2016 and 2017, where participants at those forums subsequently expressed a desire to expand these globally. We organized these symposia with the goal of sharing research on global health policy and policymaking and building a global community of researchers who apply social scientific theory and methods to the study of global health policy. Our last symposium was held in 2018 in Liverpool, England. And following that symposium, a steering committee of researchers from around the world was formed. And it's this committee that has organized this symposium. Next slide, please. The committee members, all of whom are researchers working on global health policy, have put a considerable amount of work and effort into designing the program and organizing the event. I want to note its members. Grépin of the University of Hong Kong, Aaron Mulaki of the African Constituency Bureau for the Global Fund, Marcia Orgil of the University of Cape Town, Kathy Reyes of the University of the Philippines, Manila, Carrie Scott of Johns Hopkins University, myself, and Steph Top of James Cook University. Next slide, please. As a means of continuing to build ties among researchers who draw carefully on social science theory and methodology to study global health policy, the committee is very pleased to announce today the establishment of a new organization, the Global Health Policy Research Forum. We intend through this forum to organize future symposia, as well as to undertake additional activities to build linkages among global health policy researchers from across the world. For more information and to stay engaged, please visit our website, which is listed on the slide, globalhpr.org. Next slide, please. We want to thank the Alliance for a Healthier World of Johns Hopkins University and Shapes of Health Systems Global for providing financial support for the symposium. We also want to thank Mo Elahi and his IT team, Brittany Menina and Feng Chong, all of Johns Hopkins University for their technical support for this symposium. Next slide, please. There will be 5 more panels over the upcoming Tuesdays in the symposium. These are listed on the slide. If you haven't already done so, we encourage you to register at the link on this slide, globalhpr.org. Next slide, please. Let me now turn to introducing the panelists. We selected them very carefully. They represent multiple disciplines and fields, including anthropology, economics, political science, and health policy and systems, and each is one of the world's leading researchers working on global health policy. We asked each of the 6 to come up with 5 minutes of comments on directions for the future of the field of global health policy analysis, with particular attention to how COVID-19 pandemic may be shaping this field. Clare Wenham is Assistant Professor of Global Health Policy at the London School of Economics and Political Science. She's an international relations expert who researches global health security. John Ataguba is Associate Professor and Director, Health Economics Unit at the School of Public Health and Family Medicine at the University of Cape Town. He's the leading health economist in Africa with expertise in health inequality, health financing, and health equity. Kabir Sheikh is Policy Advisor at the Alliance for Health Policy and Systems Research. He's a health systems researcher, planner, and educator working to strengthen LMIC and global health policy and systems research organizations. Katerini Storeng is Associate Professor of Global Health at the University of Oslo. She's a medical anthropologist who researches the politics of global health, including global health initiatives. Gilson is Professor, Health Policy and Systems at the University of Cape Town and at the London School of Hygiene and Tropical Medicine. She's a health policy and systems researcher with a strong focus on health policy and systems research capacity strengthening and specific experience in African settings. Sheikh Abímbọ is Senior Lecturer at the University of Sydney. He studies community engagement in governance and the role of governance in the adoption and scale up of health systems innovations. He's Editor-in-Chief of BMJ Global Health. Each of them will speak in turn, and then I'll moderate a discussion among them. And again, as they're speaking, please do submit questions and comments through the Q&A function. Grépin will select questions to pose to the panelists, and she'll ask these after the moderated discussion. So let me now turn this over to our first speaker, Clare Wenham.
Thanks, Jeremy. Thank you for having me here today. It's an honor to be with such an esteemed panel, and I thank you for the kind invitation. So I wanted to talk a bit about how we think global health policy is going to move forward post-COVID. And to me, there's one key gap thus far in how we think about global health policy, or how a lot of global health policy is created and developed, and that is politics. If we think about the coronavirus outbreak and we think about, for example, thinking how ready we were for this going into it, we can look at metrics like the Global Health Security Index, for example, and see that the countries who on paper were the most prepared to deal with a major pandemic, such as we're living in now, have been the ones who've really struggled the most. And whilst there have been suggestions that this might be to do with UHC or with capacity, to me, all this screams to me is that you can have the best system in the world, you can have the best policy in the world, but if politics is not thinking that way, or if politics is pushing other priorities, then you're going to have a problem. And I think this is where we really need to start engaging in greater interventions in global health policy analysis. We all know that policy is not value neutral. So how do we incorporate this political analysis into the way we think about global health policy going forward? Now, quite often when we talk about politics in global health policy, we get pushback from policymakers saying, don't politicize it, right? It's not a political issue. And I think the first thing we need to recognize is that there's a difference between politicizing something in terms of partisan politics and using the tools that we have in political science, in international relations analyses, and applying them to the context of coronavirus or to the context of global health policy more broadly. And I think this is where I really would make a plea to everyone to start including this type of analysis in global health policy. And so if we just think about this in the terms of coronavirus and think about how you can use political analysis to improve our decision-making around responding to coronavirus, you can see a lot of useful tools at your disposal. And the comments I'm going to make draw on some discussions and paper that I've been working on with Sarah Davis, who I think might be on this call today. But the first is that this is the first time we've had a crisis, a global health crisis, which truly is global and is affecting every country in the world in the same way. So effectively, you've got the same variable, and you can actually see how different countries are responding to it. And you can see then how successful or relatively successful these are, or what gets prioritized or what doesn't get prioritized, and what the effects of those are. Now, undertaking situational analysis or comparative analysis would allow you to really understand why this has happened, right? Why have states responded in the way they have? Why have some moved quickly into lockdown or second lockdowns, or God forbid, third and fourth lockdowns? Why have others really focused on track and trace systems and keeping everything open? Why have others prioritized economic security and stability above population's health? And this type of analysis allows you to understand what are the motivations for these decisions. Why is it that governments, when faced with the same problem, have approached them very differently? Now, you can then take this analysis one step further and really think about kind of more global decision making. Why do governments at time of crisis, why have they not worked together collectively through the normative agenda of global health governance or global health security? This idea that we all live in an interconnected world and therefore we must work and collaborate together at point of crisis. Now, that's been in a lot of the literature in global health policy for the last decades. But at point of crisis, that's not what's happened. We've seen a retrenchment to national decision making, to protectionist policies. And so I think we need to understand, why has that happened? And international relations analyses can give you those tools. It can seek to ask questions such as, why are governments not listening to the World Health Organization, for example? Has a WHO lost its authority or losing its authority? And what does that mean for other areas of global health policy development, right? Both in the short term, in terms of what's going to happen with initiatives like COVAX, but also in the longer terms for all the other things that happen in our global health community and all the research that everyone on this call does. How does changes in the way we govern outbreaks and changes in relative power and position in a governance framework affect the whole framework and microcosm of global health security actors? Now, obviously, this is also all driven by money. Who's paying for what, and how do those payments determine actually when people work together or not work together? And so tools of international political economy, for example, might be useful in those instances. So I think we really need to push this more systematically into the way we approach global health policy analysis, to make sure that at all points of the conversation and at all points of the analyses, we start to ask questions around the political drivers, the political outcomes, and potential future changes in this political landscape. One of the key things you have, and if you look at IR analyses, is that this is never a static concept. These are always dynamic. So how do you account for those dynamic processes, and how do we incorporate them both in the way we analyze what's going on currently, but also try and incorporate that more systematically and more rigorously into the policies and frameworks as they are made, so that we are not left in this position again of thinking that policy or not really incorporating political decision making in our global health policy processes. I shall leave it there. I think my 5 minutes are up.
Thanks very much, Claire, for really valuable comments on the role of political science and what political science can offer us in analyzing the COVID pandemic and many other global health issues comparatively and globally. Let us now turn to John Ataguba.
Thank you very much, Jeremy, and thanks to the organizing committee for having me here and for giving me the opportunity to speak at the symposium. I will speak as an economist, but an economist with a difference who has, over the years, seen the beauty of interdisciplinarity. I will touch on 4 key points here in terms of trying to understand the future of global health policy analysis, given the new reality, which is COVID. One is that we thought that we had learned a lot from the past, and we thought that the knowledge we have from the past should have helped us in dealing with the COVID. But unfortunately, we never saw that happen the way we wanted. The COVID pandemic reminded us so much more that we have not sufficiently internalized what we thought that we had learned from the past. A lot was studied and written regarding the Ebola pandemic epidemic in West Africa, for example. While the epidemic, the Ebola epidemic was a far smaller scale compared to the COVID pandemic, many lessons learned from the past policy analysis did not feature prominently. Examples, we've heard a lot about preparedness, weak institutions and weak governance structures, poor data infrastructure. These are many things that can be addressed cost effectively in achieving many things, but they weren't really brought on board. So we know that some countries are better prepared than others, with skepticism, especially in terms of when do we act? Do we leave it for tomorrow, or can we act now? Or what's happening in Europe? Or we can learn from Europe. It's just a game that was played without necessarily imbibing context. The next thing that I think is also important is the global connectedness was brought bear with the COVID pandemic. Your problem is my problem and also our problem. With the COVID pandemic, it became apparent that global policy analysis needs to increasingly recognize spillover effects from not only within a country, but from other countries. Economists will often see these as external shocks to the system. Whatever the name is, depending on your disciplinary background, global health policy analysis needs to, going forward, internalize these as a major aspect, especially regarding pandemics or epidemics like the COVID-19 pandemic. Then the role of the social determinants of health. In my own opinion, the COVID pandemic quickly kind of highlighted that the health systems can be weaker when we ignore many social determinants of health. Health policy analysis, which usually recognizes the importance of context, offers a window for us to assess the potential implications of paying little or no attention to the social determinants of health. The COVID pandemic had shown vividly and is still showing that ignoring context, including the role of the social determinants of health, could potentially be costly for the health sector in the long run. We have to wake up and act more, acknowledging the social determinants of health. And lastly, and importantly, beyond reactionary or ex post analysis, we need to move into contemporaneous analysis. In the wake of the COVID pandemic, people ignored policy analysis, economics, behavioral issues, and the heavy focus was put on epidemiology and other public health aspects of the pandemic. Health policy analysis was thought of as something that would be reactionary and not happening as things unfold. For example, let us just wait for the dust to settle and we shall analyze what happened with the dust and whether it needed to settle at the time it settled or not. In my own opinion, we need to continue to make a case for global health policy analysis to be living contemporaneously amid every public health issue. The COVID-19 pandemic has highlighted the need for such, and to bring me back to my first point I raised earlier, to also effectively learn from the past. We need to internalize lessons we've learned from the past and see how we can change things and not just say them without doing them. And with that, I think I will pass the baton on to Jeremy. Thank you very much.
Thanks very much, John. Some very important points about forgetting the past and not learning from the past and the need to do so. And for health policy analysis, global health policy analysis to be relevant to the present time. So for contemporary analysis. So thank you very much. Let's move to Kabir Sheikh, and Kabir will have some slides with his presentation.
Thank you, Jeremy. And thank you to the organizers for inviting me. I've been asked to start my video, so I'm going to do that. There you go. So I'm going to start right off because I have 5 minutes and I'll try and fit everything into 5 minutes. Next slide, please. So this is a quote from the Lancet, the last week's Lancet, which for me signaled, I mean, it's quite a complicated quote and a little bit unusual for a medical journal. And it signaled for me that I think what we're facing now is that there is wider recognition that COVID-19 isn't just being seen as another infectious disease, requiring a silver bullet. I mean, I think most people would agree that we would want a focus on broader appreciation of what the epidemic is causing. Although, of course, I'm sure that none of us would also mind a silver bullet at this point. But still, the main point is that I think there has been active acknowledgement from many opinion shapers around the world of the need for a broader response, and the fact that the pandemic interacts complexly with other human vulnerabilities, with other determinants of health and of the social, economic and social impacts of measures to restrict COVID, and also ultimately of the need for a system-wide approach balancing both essential and emergency services. Next, please. So while that certainly typifies the current response, we are still not sure what the post-pandemic response will actually look like. And there are pretty big questions around that, because we've seen that we have been ravaged by epidemics before, we've seen global pandemics before, and we haven't always learned, the world hasn't always learned in the way that we might want it to learn after the epidemic has subsided or after it has been controlled. So for example, many questions arise. Will we see a risk of verticalization post-COVID, with funds and functions being diverted to COVID at the expense of broader multi-sectoral and health systems action? Will we see a big focus on reviving systems and economies as they used to be before the COVID epidemic, or will there be a genuine momentum towards a more sustainable approach? Will the appreciation of sort of shared vulnerabilities that everybody is articulating at this point actually engender the continuation of a more inclusive approach to people's health? Or will we see a turn towards more exclusion and stigmatization as people start to separate themselves from people who are more vulnerable? Next, please. So my point is that in all probability, we will see variations of all of those things happening, and there's a spectrum along all of those questions. But that it'll depend a lot on context and setting. And health policy researchers will face a very interesting and a significant challenge of understanding and explicating all of these new pieces as they fall into place once the big COVID shock starts to subside. So what I will argue here is something that's been argued before, not in a post-epidemic context, but much more generally, is that the groups of actors and processes that are of greatest interest when we talk about this are the ones that are closest to citizens: the frontline workers, the managers, and the implementers of programs and policies. And so this is a sentence from Michael Lipsky's seminal text on street-level bureaucracy way back in 1971. And it refers to governments, but of course that logic can be extended to all policies, programs, and services that are oriented towards the public good. So these groups are and will continue to be the ones most directly affected by the after effects of the COVID epidemic and confronted with the most important conundrums and choices in the decisions that they take on a daily basis. Just for example, how will a district health manager cope with the potential diversion of resources for other health programs towards COVID control, which is likely to happen or is probably already happening? How will a community health worker deal with fake narratives around COVID or of the potential stigmatization of COVID patients in the village that they serve? Next, please. So if there is a big message that I would like to convey, it would be to focus on understanding better the complex relationship between policy and action, which is the field that we generally refer to as policy implementation analysis or policy or implementation research. The groups and organizations involved in implementation, not only those in the health sector, but in all spheres that influence health, will continually reinterpret, modify, and change policies in the process of implementing them. And the reality is that we don't know how these actors, the different street level bureaucrats, health workers, program managers, are actually coping right now. There's a need for much more empirical understanding of how they're adapting and the choices that they're having to make. And we need to do much more to understand the environments in which these decisions are taking place and how the implementers' decisions in turn are shaping their environments. Next, please. So at the heart of this recommendation and this focus on implementation is a philosophy and an appreciation that local knowledge and context is going to be key to the response. And we must avoid the centralization of the core concept of global health policy or an association of global health policy as referring to only what happens in the global capitals, Geneva, Washington, DC, Beijing, and others. We should embrace a much more widespread and democratic concept of what global health policy is and where decisions are being made. So before I close, I just wanted to make 3 additional points about potential directions for the HPA field, in addition to the major one that I made around the focus on implementation. The first is that COVID has revealed that health policy is as or potentially more influenced by narratives as by bare facts. And those narratives now have new and ever evolving means of transmission and dissemination. The creation and dissemination of false narratives at scale and the loss of contextualization that occurs when these narratives are transmitted globally are new phenomena, and they need to be understood much better. Discursive policy analysis is a subfield of policy analysis that's existed for a long time, and but it has been sorely underutilized in global health policy analysis. So I would really like to see more of that happening. Secondly, there's a time now when people are actually listening to health policy researchers, and we are seeing a sort of a shift of health policy into the high politics realm. That interest may or may not continue, but for now we have certain responsibilities that come with that power. A lot of people will want policy researchers to be on the right side of the debate, whatever the right side is. But policy research shouldn't just be about reaffirming certainties. It should first and foremost be about listening, increasing understanding, and promoting learning, especially of processes that are undiscovered and actors that are neglected. And my final point is that there needs to be a reaffirmation or an affirmation of commitment to equity. So COVID indeed underlines shared vulnerabilities, but let's not be fooled into thinking that we're all facing the same types or magnitudes of problems. Of all the changes in basic human development indicators we have seen in the past few decades, the one that is showing a worsening trend is inequality. Income and wealth gaps are widening continuously. We need to do and learn much more about what's happening to the poorest and most vulnerable, and keep asking the questions that are of most relevance to them. So I think I'm at my 5 minutes, so I'll close now, and back to you, Jeremy. Thank you.
Thank you very much, Kabir. I take some very critical points there about the need to consider implementation, which really is often the stepchild in policy process analysis. People focus on formulation and forget implementation, and Kabir's telling us, don't forget that, and also asking us to make sure that we consider local context as we do this analysis. That global health policy is not just about what happens in Geneva, and very important points about the values and listening as we consider this work. So thank you. We'll next turn to Katerini Storeng. Katerini, over to you.
Thank you very much, Jeremy, and thanks for the opportunity to be part of this exciting conversation about how global health policy might look in the future. My co-panelists have already noted the importance of politics and also the growing recognition that COVID-19 demands a system-wide approach that is sensitive to implementation, as you said, and also equity. Yet one of the things that's really intrigued me during the pandemic is the immense faith that is bestowed still in technological solutions. So while we're waiting for a vaccine to save us, governments all over the world have embraced digital technologies and data, big data, to support the public health response. For example, at least 50 countries have now launched so-called contact tracing apps, even though there's no systematic evidence that they support the public health response in any significant way. And my own prime minister here in Norway urged citizens here to download such an app in order to get our freedom back. In some senses, the hype surrounding these kinds of solutions is nothing new to health policy analysts. It's consistent with the techno-optimism that has been a core feature of much global health policy in the past decades. And it also echoes the optimism that's often surrounds digital health as a way for countries with weak public health systems to leapfrog towards universal health coverage on the SDGs. I've even heard digital health referred to as the penicillin of our time. But at the same time, the digital response to COVID suggests a new set of issues that I think should be on our future research agenda within global health policy analysis. Notably, the way in which it epitomizes the growing influence of the global technology sector on health policy and practice, and of corporate power more broadly. So for example, since the start of the pandemic, my colleagues and I have been paying attention to the way in which the global tech sector has entered into a variety of new forms of engagement with public health authorities with little public accountability. For example, tech executives have advised national policy in the US and the UK, with Google's head of artificial intelligence participating in early SAGE committee meetings, for example. And the WHO has reached out to Silicon Valley to help fight the infodemic of misinformation about the new coronavirus as early as January, with Dr. Tedros declaring that, quote, "We are proud to have partners like Facebook." Facebook has also shared localization data for use in modeling the pandemic spread and evaluating the effectiveness of countermeasures like travel restrictions. And perhaps most significantly, Apple and Google have become major players in the global diffusion of digital contact tracing, contributing their own jointly developed exposure notification system, which many governments are now integrating into their own contact tracing apps. So like other corporations that are involved in developing vaccines, treatments, and diagnostics, the tech companies present their involvement as driven by social responsibility. But as global health policy analysts, I don't think that we should be taking such claims at face value. And instead, we should draw on our roots in political economy and attention to power dynamics to ask more critical questions about corporate actors' motivations and stakes in the response and in public health more broadly. For example, who stands to benefit? Big tech companies' involvement clearly confers reputational benefits to them at a time when these firms are under intense political scrutiny for their size, power, and their role in perpetuating fake news and threatening democracy. They also stand to benefit commercially, whether through increased demands for their devices, applications, or data, or by establishing themselves in new public health and healthcare markets. By contrast, the benefits to the public is less clear, and critics are arguing that a heavy reliance on digital solutions may exacerbate existing health inequalities, especially in places with a large digital divide. And there may be large opportunity costs if investments come at the cost of strengthening health systems. But I think one of the most important questions for global health policy analysts in the future concerns the nature of what we mean by partnership when we're talking about private sector actors and public health authorities. In the case that I've been discussing, Apple and Google say that their work on digital contact tracing is about helping governments and citizens. But on the other hand, their involvement also exemplifies these companies' growing political power over states, with the companies setting the terms through which public health authorities can actually use technology and even access data about their own citizens. Only a few countries, including France, have spoken out about what they perceive to be attacks on their digital sovereignty. And in July, it was really interesting to read that an advisor to Latvia's prime minister accused Silicon Valley of building a brick wall when her country tried to develop their own technological solution to contact tracing. And she asked a really pertinent question about how far private tech companies can go in dictating the health policies of sovereign democratically elected governments. And I think that is precisely the sort of critical question about the role of corporate power that global health policy analysts should be contributing to answering in the future. Thank you very much.
Thank you, Katerini. Some fascinating comments about techno-optimism and corporate power and not taking that power for granted, its moves, and interrogating and thinking about its effects on health equity. And I think an extremely valuable perspective on this issue. Okay, so next, let's turn to Lucy Gilson. And Lucy also has some slides, so we're going to put those up.
Great, thanks very much, Jeremy and others, for inviting me to be part of the panel. It's good to be here. I want to start my reflections by referring to this recently published commentary in the journal Health Policy and Planning, co-authored by scholars from around the world and focused on research for low and middle income country settings. The commentary emphasizes the central role of research about the politics of policy processes within the broad field of health policy and systems research. And in these COVID times, it emphasizes the need more than ever for activist research, supporting the emergence of health systems that contribute to social justice. Next slide, please. One thing the commentary does is to offer some thoughts about research questions for COVID times, These include questions addressing the politics of decision-making and the linked governance issues within health systems. And the questions address experience at all levels, local, national, and global. Next slide, please. But for today's discussion, perhaps more important, is the commentary's call for reflection on the power imbalances within our knowledge communities and the need COVID has emphasized for richly contextualized understandings, both of health inequities and of current policy strategies and processes. This is the foundation for action to address inequity. Next slide, please. Recent African HPSR discussions have both demonstrated the depth and richness of our knowledge communities and also affirmed the need to deepen and strengthen them. This slide is a visual image of the discussions on one day of one of these convenings, all held in preparation for the Global Health Systems Research Symposium that will occur in a couple of weeks. I hope this slide conveys a little of the vibrancy and color of our engagements and the opportunities there are to reimagine health systems in Africa and in other settings. Next slide, please. So how do we deepen health policy analysis work in low and middle income settings? At one level, there simply has to be more LMIC-led research in LMICs. And there needs to be the institutional supports for this work. In addition, researchers in low and middle income settings need to develop stronger links across disciplines with social scientists as well as other health disciplines. But they must also engage more deeply with other forms of knowledge, indigenous and community knowledge, and the tacit knowledge of policymakers and managers, the street level bureaucrats that Kabir has also mentioned. Such engagement will contribute to research rigor and support richer and thicker understandings. It will itself be supported by new research strategies and approaches, such as embedded and co-production research, and the use of arts-based strategies that can deepen insights into the lived realities and everyday worlds of policy actors. Next slide, please. And within LMICs, we need to develop programs of work implemented over time. At present, there is commonly too little HPA work in any one setting, but also the current research is comprised often of multiple scattered, quite small scale studies. Within the funding constraints within which we work, we nonetheless need to develop larger research programs that allow our ideas to develop, be tested, and be refined over time, that test and generate theory, that allow the dynamics of policy change over long periods of time to be tracked. We must also explore options for cross-country work that emerge in a way bottom up from the work that is happening within countries. And of course, we must engage with global influencers and with global actors. But finally, it is imperative that in these days of growing inequity, inequities that COVID has only exposed, that we adopt an activist research agenda that in the best traditions of policy work speaks truth to power in our discipline and in our societies. Thank you. Over to you, Jeremy.
Thank you very much, Lucy. Some very powerful thoughts and ideas. I think that a phrase that really struck me in what you said is power imbalances in knowledge communities, and the need for our fields to grapple with that, to make sure that that our knowledge is contextually relevant, that HPA is embedded in LMICs, but also points about extending the research agenda long-term, deepening it theoretically, and making it relevant and activist in orientation. So thank you very much. Okay, let us now turn to our final speaker, Sheikh Abímbọ.
Hello, everyone, and thank you for having me. Thanks to the organizers for the opportunity to speak. Having listened to all that has been said so far, I have a sense of deja vu of during and in the aftermath of the global financial crisis in 2007, 2008, when there was a lot of call for soul searching among economic policy analysts. And my sense is if our field of global health policy analysis were to go through such a reckoning in the wake of the COVID-19 pandemic, I think two things will stand out quite prominently. And these are two things that are even more significant, given that there's concurrent agitations along with the COVID-19 pandemic around Black Lives Matter and decolonizing global health, etc. And in many ways, these two issues that I'm going to raise also speak to the fact that our community, to some extent, have been surprised by the unexpected patterns of performance of different countries and different locations in response to COVID-19. So two things that I'm going to talk about. The first is taking our distance. And when I say our, I mean any health policy analyst anywhere. Our distance from the realities that we seek to analyze and understand. And the second point is our sense of default when we analyze policies. What is it that we are comparing them to? What are the default settings we have in mind when we do so? So I'll speak to the first point now. So there are, in many ways, implications of our distance for what we can know about health policy in a place or globally, what we can say or what we can recommend about health policies, and as to whether we speak in specific terms or in abstract terms as health policy analysts. We all work at different levels of remove from the policies and the realities that we analyze. And I wonder what it will look like if we took that fact seriously and acknowledge and declare and interrogate our distance from realities as a central feature of our approach to analysis. Of course, we would have to re-examine our positionality as analysts and what that implies for what we may be able to claim to know about any issue or about any location. And I think that will also force us, as Lucy and Kabir mentioned earlier, to reckon with the place of local knowledge and in how we construct our analysis. And also, perhaps, especially in the context of COVID-19, it will also force us to reckon with the limits of what we call the literature, which the way I've grown to see it is a very, very poor reflection of reality. In part because, as Lucy mentioned, it fails to capture that long-term organic process that's often involved in policy making and policy implementation and the consequences of those. And reckoning with that, with that sort of ignorance about much of the world and much of what we seek to analyze, will make us think, hopefully, more critically and more carefully about what we may claim to know or what we may want to recommend to anyone. So the first point there is about taking seriously the extent of our ignorance and the extent of our distance from what we seek to analyze and make sense of. The second point that I want to make is about our default setting, sort of mental frames that we bring to the issues that we seek to analyze. Whether we acknowledge it or not, or whether we are aware of it or not, policy analysis is often informed by an often undeclared sense of ideal of what is good, what is desirable, what are the appropriate institutional arrangements or policy settings that bring about our desired goals. And in many instances, to construct that ideal, we look to some high-income countries. So when we say we want change, we often seem to typically mean we want to look more like Europe and North America. And I think this is a rather blinding assumption that we would hopefully have to undo and examine and interrogate systematically in the ways in which we analyze health systems and health policies. And I should also say that the default setting that we have to be mindful of is not only where the idea, what the idea of ideal is, but also where policy ideas come from and where frameworks that we use to analyze them come from, and the assumptions that are implicit in those frameworks and in those policies, and what kinds of realities and values they often leave out. And I suppose what I'm trying to get at with this second point is that our analysis of the world and of health policy and systems would need to imagine a flatter world, a world in which we progressively do away with the distinctions we often run to in drawing lines between high-income countries and low-income countries. Those are very, very big categories. And to do away with those default assumptions and settings that we have in our mind, I think one of the key potential benefits of doing that is that knowledge and learning can flow more easily from place to place. If there's one lesson to take from the experience of COVID-19 and what we've been able to know or not know so far, is the idea that the world is much more flat than we often assumed it to be, and that learning and lessons and expertise and brilliance and excellence often belong in places where we've not often looked to for those things. And if we want a more equal world and a world that learns to respond better to things like COVID-19, then we need to assume a much flatter world. And I can't, prediction is always a very inexact, but I suspect that this is where we will likely find ourselves in the future, a place where we see the world as a much more flat place, a place where learning should be at the center of our analysis, and also a place where insights can flow from one place to another, regardless of what the assumptions we've made about how excellent and brilliant, etc., those places might be. So that's the second point. And so 2 points, distance and defaults, I think are the things that would need to reimagine as we analyze policies going forward. Thank you.
Thank you very much, Sheikh. Some very powerful ideas pertaining, I'd say, not to knowledge, but to ignorance, right? How our positionality and pre-existing mental frames distort the way we see the world, and perhaps silences particular perspectives and voices that need to be brought to the analytical field, as you say, in a flat world, and drawing from frames that often don't get heard. So very powerful ideas. Thank you. If I could ask all the panelists to come back on screen, what we're going to do and I'm just going to pose 1 or 2 questions to the panelists, because I think, Karen, correct me if I'm wrong, but you've been getting lots of very good questions, and I want to make sure that we have plenty of time for people listening in to pose their questions to the panelists. So I probably will just limit my questions to 2 and then turn it over to Karen. Just a comment that I heard a lot of overlapping themes. I think the audience will agree that we selected very wisely in terms of who we invited to speak, because each of the 6 offered very powerful ideas that help us advance this field. But I heard everybody speaking about power and power imbalances, about ethical issues, norms, how we need to infuse these in the work we do, particularly surrounding health inequities, about relevance in local context, and the need to make sure that our analyses are not just, as Kabir says, about what's happening in Geneva, about positionality and local knowledge, and the need to incorporate that in our analyses. So with that in mind, let me ask 2 questions. The first one is sort of more of a macro question, and in some ways many of you have already answered it, so if you feel like you already answered it, don't feel like you have to jump in on this. But I see how we have people coming from many different social science disciplines, both in the audience and on our panel. And I'm wondering if you were to highlight one theoretical or methodological idea from your primary area or discipline of training that you think the rest of us or much of the health policy analysis world doesn't get or doesn't consider sufficiently, and that you would like to inject in the field for inquiry. What would you tell us? Because we have anthropologists, economists, political scientists, policy and systems researchers, and I don't know how you're all self-defined. But what do you want to inject in the field, theoretically, methodologically, to help us grapple with these issues of? I'll leave that open to everybody, and I apologize if you think that if it's like I'm just repeating kind of what you already said. Go ahead, Katerini. Just raise your hand.
Thanks, Jeremy, for that question. I thought I'd just start. I was really intrigued by all the talk about politics, and as an anthropologist, I guess one thing that anthropology could contribute to this discussion is attention to not just to politics in the sense that Claire was talking about, but also to the micropolitics of global health. And I think, Jeremy, you raised really interesting discussions about the role of power in global health several years back, which initiated an interesting discussion about that, where you talked about how it's useful to think about global health as a field of complex power relationships, right? In which actors aren't only pursuing normative goals, but are actually also using their expertise and moral authority to gain influence and pursue organizational and national interests. And I think that anthropological methods can be helpful in trying to unpack some of those dynamics through ethnography, for example, which involves immersion in communities. If we're looking at health policy, we're not talking about the traditional sense of an ethnographer immersed in a little village to try to understand local practices, but trying to understand the micropolitics of global health through immersion in expert communities and policy environments, and trying to unpack through interaction, conversation, participant observation, and in-depth inquiry what the different stakes are. And so I think that's what I would like to contribute from anthropology in the first instance.
That's great, Katerini. I'm hoping that you or your fellow anthropologists will write a paper that tell us how we should be doing this, because I think that's a wonderful idea. Others?
Can I
Yes,
go in there? John here. Thank you very much, Jeremy. This is a very interesting point you raised. As an economist, one of the things that I've learned with the COVID pandemic and many other things is the fact that we're not paying enough attention to equity. There are many policies that were put in place when COVID-19 hit many countries that were based on, like Sheikh talked about, well, this is what happens in developed countries, so we can import it and try it out here. There was no attention given to context, which is very, very important. It's very difficult to transplant something that happened even in Nigeria and take it to a neighboring Benin Republic because the contexts are totally different, even though they are very close to each other. So in that regard, what I'm looking at is the COVID-19 pandemic has taught us that if we look at any policy, there needs to be a quick analysis of equity. Who is going to benefit from that policy? And who stands to lose? If the people who would lose from such policies are people who the policy seeks to protect in the first place, there is a problem. There is a big problem. We've learned how many businesses suffered. And in some countries, for example, policies were in that harm migrants, for example. And even if there was consideration, there was this kind of division between you coming from Asia, you brought this disease. Oh no, you coming from that, you brought that. So there is need for us to begin to look at each policy, who benefits and who doesn't benefit from the policy. And such analysis could be gendered as well, because the COVID-19 pandemic has widened not just any inequality, but gender inequalities, which we wouldn't have seen much of that without the COVID. So the COVID has heightened many things, including gender-based violence. Such policies can also be useful to, well, very useful to analyze policies to see the impact they will have on inequalities and equity. Well, that's my own token as an economist. Thanks.
Great. Thank you, John. I imagine multiple disciplines can analyze inequalities and inequities, but economics has particularly powerful tools to do so that we can leverage to understand these dynamics. So thank you. Claire, did I see you raise your hand on this?
Yeah, I was going to sort of jump in and say something sort of in between of what Katerini and you were saying, Jeremy, which was that actually sort of international relations as a discipline can bring some useful bridging tools to thinking between anthropology and political science. You know, when people talk about political science, often people think about it as a very kind of quantitative discipline. And actually, you know, we've got a lot of qualitative international relations going on, which really does some of this storytelling narratives and trying to kind of push the boundaries and talk to decision makers and understand why they've made these decisions, or look at things and understand what's missing from these conversations, which is equally important, going back to what John just said, right? If you're not in the policy, you're not considered by the policy. And so I think actually that there's a need for all of us, and myself included, to think beyond how we perceive different disciplines. You know, if you always think about anthropology being, 5 years staying in a village, that isn't reflective of what anthropology is, in the same way that thinking about kind of, very quantitative political science isn't representative of the whole discipline of political science. And so I think as researchers, we all need to kind of actually learn what each other do a bit more. And I think that makes a much more fruitful way moving forward for global health policy analysis, because actually, if you know what people can and can't do, then that allows for much more fruitful collaboration. And I think, if anything, this outbreak, as with previous health issues and previous outbreaks, have shown that actually it's the real developments happen in this field is through interdisciplinarity and working together. And that's only going to happen when you really understand the breadths of different disciplines.
Right. So, thank you. Just 1 second, Lucy. Yeah. So, as a fellow political scientist, Claire, yeah, I can affirm that the multiple traditions in political science, including qualitative and influenced often by sociologists in some of the constructivist type analysis in our field that seeped in, which is good, and maybe less so by anthropology, but we probably need to be more influenced by anthropologists in the way we study the world. So the cross-fertilization is one of the key themes. The cross-fertilization of fields and disciplines is really one of the whole imperatives for this organizing committee to want to put together this forum. So we appreciate that comment. Lucy.
Thanks. I want to speak about a concept, if you like. So firstly, I should say that health policy and systems research isn't a discipline, it's a field that draws on multiple disciplines. But secondly, I want to re-emphasize the point that Kabir made, that in thinking about policy, the idea that policy is practice, that policy only has impact on people's lives when it is translated into practice and behavior changes in communities, in health facilities, wherever. I think that is a central concept that we have to work with in thinking about how to bring about difference in people's lives. The best designed policy may not generate the changes that analysts suggest it might. And if we think about practice, then we clearly have to think about the chains of relationships between people through which policy infuses in the world around us. And all the different methodological and disciplinary insights that allow us to understand those chains are really important to grasp and to use. Thank you.
Yeah, great point about translating into practice and how we think about these processes at work. And it's good that you mentioned that, yeah, health policy and systems is a field, not a discipline. Some of us here are represented by disciplines, others by field, and it's important to understand these distinctions. So thank you, Lucy. I saw someone else's hand, sorry, I missed. Was it Kabir or Sheikh? Kabir, please.
Thanks, Jamie. And really building on what I think Lucy said, but also on this point about how we look at the production of knowledge and then how it actually has an impact once it's produced. And I suppose if there was one, I wouldn't call it a methodological point, but more of a philosophy from health policy and systems research debates that a lot of us engage in, is how to orient health policy analysis more towards promoting learning, towards advancing learning. And I think there are some sort of niche things there around. I mean, I'm sure Sheikh would have something very interesting to say about how his journal has been really involved in advancing a different way of publication that promotes deliberation and learning through deliberation. So, inviting different perspectives. But I do genuinely think there are several steps that need to be taken and can be taken to actually advance learning at every step of the way. I mean, the obvious ones are engaging audiences as early as possible in the process of creation of knowledge, ideally even at the stage of setting research questions, co-creating research wherever possible, while also being aware of power differentials and making sure that researchers have protections and aren't always, serving the needs of people in power, but are able to produce research independently. And ultimately also generating messages in ways that advance learning. So there again, coming back to this, how do we create outlets that promote deliberation rather than, just statements and assertions? And I think that's really key. And I'm sorry, that doesn't provide a single answer, but I think it's more of a mindset change in how we deal with evidence and how it works towards change.
Thanks, Kabir. Very important comments that build on learning and the importance of translating this into learning. I'm just going to ask one more question. Actually, it'll build on stuff you said, Sheikh. So, and then I want to turn it over to Karen. For the audience, just to know, we're going in, this is an 1.5 hour long session, so we still have 25 more minutes, so we're going to have time for audience questions. But let me just throw in one more comment that builds on what Kabir says and some of the points Sheikh and Lucy raised. And this is the question of power over the control of knowledge. Lucy spoke about the balance of power among knowledge communities. Kabir was speaking about the need to promote learning. Sheikh spoke about how our positionality, I think in essence, although he didn't state it directly, promotes ignorance sometimes. It gets in the way of us knowing. I wonder if we could hear from people about how we get it right in the field of health policy analysis and global health policy analysis with respect to altering the balance of power among knowledge communities, with respect to challenging our pre-existing presumptions. What specific ideas do we need to do to address power imbalances, not in the world, but in our field? We're all scholars, we're all researchers, we've all produced knowledge. We're not outside of it. We're all part of it. Any thoughts on how we address and produce more equitable knowledge?
Shall I go first? So I was, what I was going to say in response to the previous question, I think also doubles as a response to this second question, which is if there's an idea that I want people in sort of health policy and systems research field to I think take much more seriously, it is the idea that knowledge is very, very widely dispersed in society, and that to really reckon with how policies work will require that we have as many as possible people around the table around which knowledge is generated and used. And so if there is a concrete idea that I've been thinking about a lot lately as to how we could sort of redistribute power a little bit, it is, I think, to better focus on the kinds of knowledge that is generated in practice and to find ways and platforms through which those kinds of knowledge can be surfaced.
Your last sentence got cut off, at least for me. Could you repeat the last sentence, please? I think you made an important point.
So I think I was saying something to the effect that if there's a way to redistribute power in the research or knowledge community, it is to better recognize the kinds of knowledge that is generated in practice. For example, by implementers within communities, by frontline service providers, and on the interface between service provision and use. Those kinds of knowledge need to find their way onto platforms that allow broader engagement with them. Currently, my sense is often that the kinds of knowledge we engage with are very clean-cut, perfectly curated kinds of knowledge that are sort of dumped onto platforms. But if we really want to change our perspective on where knowledge is and what kinds of knowledge resides in different places, we need new platforms, and we also need to hear craft new strategies for hearing from people from whom we are not used to hearing from.
Great, thank you. Let me just take one or two more comments from the panel. I want to make sure we have time to turn it over to Karen so we get questions from the audience. Katerini, did I see your hand up?
Yeah, I just thank you, Sheikh, for those comments. But I just wanted to add also that when we're talking about how to make the distribution of knowledge more equitable and altering the balance of power within knowledge communities, we also need to talk about the political economy of research. And the fact that so much of what we call global health research or global health policy research even is funded by donor agencies and philanthropic foundation based in Northern European and American North American countries, and that are very often directed or restricted to institutions in those countries. And of course, this sets the parameters for a lot of what happens. But in addition to that, I think also the systems through which we evaluate the quality of research, and journals have an important role here that we've discussed before, also set certain constraints on what sort of research and knowledge is considered interesting and valid and publishable. And the incentives that exist within that system create disincentives against the sort of research that Sheikh is advocating for. And so I think we need to be cognizant of that as well.
Right, of the political economy and the factors that shape our field as we get to publish. Claire, yes.
Thanks. I think the other question, and certainly maybe this is goes beyond the scope of this conversation, but I think it's important to raise, which is when you think about global health policy and actually what research gets, engaged in policy and what policymakers use. I think we need to ask this question around kind of, why is epidemiology, for example, the holy grail, right? And why is all policy simply based on that kind of positivist clinical epi framework? And actually, yeah, I'm not saying that's not important, but a lot of decisions are just like, let's get that data and we'll make the decisions on that, not thinking that actually each one of those cases is a person, right, who's embedded within a broader system and within broader issues. And I think that the change is going to happen when we can have that conversation with those people who make the senior decisions in governments and in WHO to say that you need to go beyond. Because often my experience has been this is an afterthought that happens sort of at the next step or kind of down the line. But why can't we be asking that question, all the time and embedding that at the start?
That's giving me an idea for another forum we ought to have, Claire, about penetrating this space, given the value but dominance of epidemiological thinking. It's valuable, but it's not the only way of knowing about the world. So I appreciate that thought. Okay, well, thank you for these very thoughtful comments. Let's turn this over to Karen now. There's been a lot of questions coming in from the audience. I'm afraid we won't have time to get to them all, but I'm sure Karen has picked out some very thoughtful questions for you.
Yeah, so thanks everyone for those great questions. As Jeremy says, there's a lot of them, which is fantastic. So what I've tried to do actually is to try to aggregate them a little bit so that I'm capturing a lot of your similar questions into one. So I think the first question is, it was raised by a couple people, Harry Coleman, Michael Harvey, Cadest Matthews. I'm sure I said your last name wrong. So this is great. It's wonderful to hear all these wonderful views from the disciplines. However, there's, this sort of talk about how to make these questions a little bit more concrete. How do you take some of the lessons from your fields and to lead to more practical solutions, especially those that have been raised by COVID? So basically, how do we move from these kind of wonderful research-oriented discussions into ways of making our research more practical and concrete for policymakers? Lucy, please.
So I have a response that perhaps doesn't directly address that question, but I think that we often assume that research generates solutions that we pass to policymakers who may or may not use them. But researchers are not only researchers in many places, they're also educators. And as educators, we have opportunities to draw on our research in ways that then inform our education of those who are decision makers. And so research can be brought to decision makers' attentions through the education process in ways that are incredibly powerful and often under invested in, if you like. So I think that it is important to acknowledge that education role, which is part of broader learning. So that's one thought. Thanks.
Kabir?
So I mean, it's a big question, isn't it? It's the whole knowledge to policy question, really. So, and I think there's two ways one can look at it. And one is how can researchers be more effective in communicating their messages? And I mean, at the heart of it, there's many complex considerations along the way, right from how policymakers actually make decisions and how they might take evidence on board while making those decisions through to how evidence is communicated. There's a whole field of study. But if one was to point towards sort of how one works towards practical solutions, I think clearly, obviously for researchers, it's more complicated. But if one turns it on its head and thinks about what are the learning needs that decision makers have, I won't use the word policy makers, decision makers, because I think decisions are made at all levels of the health system and not just at the top. Then I think it is possible to think about how one might service those needs better. I think in my interactions with program managers and policymakers, I find that very often they have, they do want to learn from the evidence and they do want solutions from evidence, but they don't often get it in the form that they want. So one, obviously there are many ways in which that's been experimented, but I think the real answer ultimately is institutionalization of research into health systems and into programs. And there is again a body of literature on that, but the obvious thing that comes to mind if you're talking about very practical solutions for decision makers are rapid review units, for example, where you actually locate researchers within ministries of health and they can actually collate and synthesize evidence for you very quickly and produce that. So I think it all really comes down to building the capacity in context that is required to serve those particular learning needs that decision makers have. I don't know if that answers the question, but it sort of addresses it.
John?
Yes, thanks. I don't know when I'm going to answer the question, but I want to put something again in the basket. There is this general notion when you talk about research, even in public health or health policy or health systems research, there are different kinds of research. Not all research is for policy. I think it's important we kind of highlight this. There's this general notion that the moment you're a researcher, you must be into policy. There are some people who are devote their lives hardcore to trying to figure out something that may not directly, indirectly gets into policy, but may not directly be linked to policy. So we should not try to kind of put research in one basket and say, well, let's see how this links directly to policy. But it's encouraged to have research that has meaning, whether in terms of policy or changing practice or even changing how people are being taught. These are kind of research areas that people go into. That's on the one side. I would also argue that research is politics in itself. So the politics of research is something that is heavily not looked at. One is that it could be driven purely by a funder. And if it's driven by the funder, it may not translate to policy because it's only serving somebody who's funded you. So we should also keep in mind that maybe we need to come back to what others say, decolonize who funds research, and also, even if we cannot do that, how research is being used. Africa, for example, I would argue is basically a net loser in that regard. We kind of open to anything that comes, so long as it generates money, we get our heads into. We find it difficult at many times to have our own agenda, you know, and that has really been a bane for us to move on many fronts. Many of the things we use, theories and methods and ways of thinking, have been dictated largely by the so-called global north. And if you have something contrary, it's not science. So I think it's important that we begin to think about, like a friend would tell me once that we lived in Nigeria, we used to know the river called River Niger. And we used to live there. It only took somebody to come to tell us that this is River Niger. And we say, oh, is that River Niger? So these are the kind of things that we knew these things exist, but our stories are not known unless it's being told from the sun. So I think just to put it in the pot, I'm not sure whether I answered the question, but this is something I want to say. Thanks.
Katerini.
Sorry, thank you. I want to go back a little bit to what Lucy was saying about research as education as well. And I think that we need to maybe challenge the assumption that there's always an instrumentalist relationship between research and policy, some sort of direct translation of knowledge into practice, and also consider the more diffuse ways in which what we call research influences practice in the longer run. And think about research as also having a function in posing new questions and making us challenge taken for granted notions. And when I say us, I don't mean just policymakers, but also the public. Researchers have an important role in challenging the terms of public debate, like Clare has been doing in the British media, like Sheikh has been doing through our field. And I think it's really important to consider that aspect of policy as well, having a role in changing the way in which we approach what we take for granted in the politics of health.
Great. In the interest of time, I'm going to move on to the next question. So there were a number of questions that came in around the concept of interdisciplinarity or multidisciplinarity. And so, for example, this is great that we have these wonderful disciplines represented here. However, what about other disciplines such as basic sciences, natural sciences, even epidemiology, or the arts and humanities? How do their views fit in? Also, given that different fields have different methods, different disciplines, and this is sort of picking up a little bit something that Sheikh said, how do you know which is right or which is best practice in terms of influencing outcomes? So if we move towards these different views and incorporating them in, how do we reconcile and decide which voice matters the most?
Can I go first?
Yeah.
Yeah.
You want to take that one on?
So I think there's often an assumption about decision making as discrete events in time that policymakers, decision makers use evidence and move on. But often it's a long process of learning and relearning and explaining and negotiation. It's a much more organic process than our language would suggest. And I think that is also important in terms of how we see what kinds of knowledge is useful and what kinds of frameworks are useful. So in my view, it would always be a locally determined kind of answer. So for example, if you're working with a community group, a civil society organization that's trying to challenge some policies in a particular setting, there are kinds of lenses and frames you bring to that setting, which may be different from the lenses and framings you bring to a global policy agenda. Say you want to influence how WHO thinks. So each, I think it's important to also to frame or think about what that question means in terms of what it is, the knowledge production and use process, what the goals are of those processes. Because I think it would vary from context to context and from use, in quote, to use.
Lucy?
So, I mean, I think that the humanities have a really important role in helping us understand our world. And research is a way of understanding our world. And so humanities offer approaches to that understanding that are incredibly valuable, particularly, as I think I said before, when we're trying to understand everyday lived realities. So I think there's absolutely a need to draw more on humanities, arts-based methods, and so on and so forth in policy work. Thanks.
Kabir.
Thanks. So small point, but and maybe a little bit of a tangent, but I think, so how different ways of communicating knowledge and information and how we can use them. I think in some ways, I made this point earlier in my presentation that narratives are as important as facts. And I think that comes down to, I mean, I think that's a universal phenomenon in sort of, society, that we see that people watch movies, people read books because they're narratives, you don't necessarily just want to, and they're influenced by them. And I think there's something to be said about how the scientific community might have created a certain type of hegemony of narrative, which is not necessarily appealing to everybody to the same degree. And that's the reason why we are seeing a global rise in populist movements, because that's not the narrative that people subscribe to or people like or people believe in. So I think it's that's really something, and that sort of clash of narratives, clash of approaches is something worth looking into for health policy analysts. And again, I think there is a field of critical theory that does this. It explores why certain ways of framing problems and solutions, why certain ways of framing stories and their predominate over others. So I think there's something deeper there, but it needs exploration. And again, I think the arts and humanities, maybe there's also a lesson for us there in how we communicate our messages, and whether we should only be communicating them through journal articles, or whether there are more creative and interesting ways of communicating that go beyond just the utilitarian function of conveying your message, but really about promoting different ways of engaging with knowledge. Over.
Great, so one more group of questions. So this idea, I think Lucy mentioned about speaking truth to power. A couple of people sort of raised this and sort of said, is it, so one, is there really a dichotomy between being researchers and being activists? And then some questions are being raised about how do we actually practically do this if, as researchers, our paychecks, our promotions are really tied to us promoting research and getting top publications. How do you reconcile this need to be a researcher on one hand and to be engaging in ways that are changing outcomes on another?
I'm happy to start off. No, everybody else has contributions. I mean, I think there's no question that the political economy of research has to be considered, and it shapes behaviors. However, I think speaking truth to power doesn't necessarily mean confrontation and lots of risk. I think it means engaged, honest conversations. And I think that is possible in particular settings as one builds relationships and networks with decision makers, with the range of people whose lives, you know, we seek to support and engage with. So I think speaking truth to power is about being ready to take difficult positions, but it's not always about contestation. It's being willing to engage. That itself can be a risk. But I think as researchers, if we seek to make a difference in the world, we have to be ready to risk something. And that risk is a risk that obviously each of us has to judge for ourselves. Are we willing to take that risk? Thanks.
Katerini.
I just want to second that, and I really think it's an important message to say that speaking truth to power is not necessarily about confrontation or conflict. And I think it's useful for researchers to think that the way that we ask our questions also helps to speak truth to power by challenging the taken for granted assumptions of power. And so I think by the very nature of the sort of research that we are engaging in, we are contributing to that sentiment. Thanks.
Great. So with there just be, Claire, do you want to have our last comment? And then I'm going to pass it back over to Jeremy for some final comments.
Sure, absolutely. And apologies, my internet cut out before, so I missed a bit of the conversation. But I also think it's important to consider the power of researchers, not just in terms of who's funding us, but our own, not only our own institutions, which are important, but also, you know, who's listened to. And, you know, not every researcher in the world is listened to. It tends to be the ones who are the most senior, for example. And I'm not suggesting that that is wrong. Obviously, people get into positions of seniority because of excellent work. But I think that means we also have to recognize that who isn't listened to as a consequence. But also on that, there's other ways of being activists, right? Being an activist researcher doesn't mean being on the front lines of a picket. It can mean, you know, making sure you are always part, you know, it can mean chipping away conversations where you can. It can mean, you know, publishing beyond the academic sphere, for example. It can mean working with NGOs and other advocacy groups. So I think it's also about recognizing, you know, what types of power, where, and what else we could be doing.
Great. Well, thanks for that. I'm going to pass it back to Jeremy now.
Great. Well, I just a quick concluding comments. I just want to say that on behalf of the 7 members of the organizing committee, we really want to express our tremendous appreciation to the 6 of you. We thought that we would get an extremely thought-provoking conversation on how to advance our field and the power dynamics in this field, and we got it with having invited 6 of the leading thinkers in this space. So we want to thank you. We also want to thank everybody who attended. There were so many questions, and I know we didn't get to them all, but the good news is that this symposium continues over the coming Tuesdays. Here's a list of them, and we can continue these debates in the upcoming panels. There are 5. If you haven't registered, please register at the website here. And we are also, the 7 organizers, and we hope others will join us, are hoping to organize future symposia. So thanks again to the panelists, to the audience, and we look forward to seeing, hopefully, most of you on 27th October for our first formal panel, Who is Heard and Silenced in Health Policy Making. So thank you, and good night or good morning or good afternoon, wherever you are.